Thank you for being here today to listen to my senior thesis presentation. My name is Megan Eimers, and I will be presenting on my thesis, Family Matters, Exploring the Role of Loved Ones in Medical Decision-Making in Alzheimer's Patients. So before I start, I just wanted to give a brief overview of what I'll be talking about today. So to begin, Dr. Semine, we can't hear anything.
I think you may have to be unmuted for us to hear the presentation.
Whether a patient can make decisions for themselves and be, quote, the source of authority over themselves, end quote. Oftentimes we see this with adults being able to consent and make decisions for themselves, but there is also this thing called familial informed consent, which we thank you for being here today to my senior presentation. My name is Megan Eimers, and I will be presenting on my Family Matters, Exploring the Role of Loved Ones in Medical Decision-Making in Alzheimer's Patients. So before I start, I just wanted to give a brief overview of what I'll be talking about today. So to begin, I will touch on why I chose my topic. Then I will go and define some terms that are important to my thesis. And then lastly, I will go into my thesis, explain it, and give some reasoning behind my thesis. So now to begin, So why did I choose Alzheimer's disease in the first place? So my fascination in learning about Alzheimer's disease first came when I began volunteering at an organization called Age of Central Texas my sophomore year at St. Anne's. Age of Central Texas offers daily care and other programs for older adults. And while I was volunteering here, I worked with the Memory Connections program, which works with adults suffering from Alzheimer's and dementia, and aims to boost their memory and also help them accept their diagnosis. So I helped with the participants remember some songs, stories, and memories from their childhood. And we did this through art therapy, music therapy, or creative writing. I also had the opportunity to talk to and interact with the families of these Alzheimer's and dementia patients when they came to pick up their loved ones. And I was able to observe the important part families play in caring for loved ones, especially in the more advanced Alzheimer's and dementia cases. In addition, I've always been interested in medicine, which is why I wanted to start volunteering with AGE in the first place. Pediatrics is actually what I've always wanted to be interested in, but through volunteering with AGE, it really opened my mind up to healthcare beyond pediatrics. And then lastly, my junior year of college, I took medical ethics with Dr. Cherry and learned about ethical decision-making practices in medicine. And this expanded my view of these Alzheimer's and dementia patients and helped me better understand the complicated role of informed consent and healthcare practices in different situations. So now to explain some terminology important to my thesis. According to the National Institute of Aging Division of the National Institute of Health, Alzheimer's disease is an irreversible progressive brain disorder that slowly destroys memory and thinking skills and eventually the ability to carry out the simplest tasks. Alzheimer's disease is the most common form of dementia, a general term for people experiencing problems with social interactions, cognition, and memory, which affects millions of people in the United States. People suffering with Alzheimer's disease struggle with memory loss, which can result in difficulty in making decisions. Therefore, when learning about Alzheimer's disease, it is important to analyze the competency of patients and to learn about terms such as informed consent and personhood in that context. So, informed consent is the moral authority to make decisions. Normally, when we think of informed consent, we think of individual informed consent, where the patient can make decisions for themselves and be, quote, the source of authority over themselves, end quote. Oftentimes we see this with adults being able to consent and make decisions for themselves, but there is also this thing called familial informed consent, which we often see when patients make medical decisions, or when parents, make medical decisions for their children until age 18 in the United States. So competency in this context, in the context I will use it, examines a person's ability to make reasonable medical decisions for themselves. Whether someone is competent or not is extremely hard to determine, but there are a variety of tests physicians use to best understand competency, such as the mini-mental examination. Specifically with Alzheimer's disease, there's definitely a spectrum of competency in which some people are still very competent and have the capacity to make these larger decisions, while others cannot. Also, an Alzheimer's disease diagnosis does not automatically mean that patients are not competent. Over time, Alzheimer's disease patients lose their ability to think properly and make decisions, and thus competency changes along with that. And then the last term I want to address is personhood. Personhood is the status or condition of being a human being that has reasoning and moral capacities. The problem with personhood is that it is difficult to know for certain whether someone is a person in this context, and whether they can make decisions for themselves. By investigating Alzheimer's disease and these ethical terms, I came up with a research question of, are Alzheimer's disease patients competent to make their own medical decisions? But this question is something far too complicated for me to answer because all Alzheimer's disease patients are different, and there is a spectrum of competency in which patients become less competent with time. So it's really hard to find that distinction, or it's really hard to make that distinction of whether or not a person is competent to make a decision or not. So this led me to my thesis, which states that the family ought to play a role in informed consent and decision-making for people who have Alzheimer's disease for the following reasons. First is the spectrum of competency I've been talking about. So as previously discussed, Alzheimer's disease patients are competent early on in their diagnosis, but it's a progressive disease. And so with time, these patients start to lose their cognition, their memory, and their decision-making abilities. When this happens, the family must play, or ought to play, an increasing role to aid the patients as they become less capable to make decisions for themselves. In this way, competency is more like Indonesia than Australia. And by this, I mean there are many different levels of competency within Alzheimer's disease patients, and not everyone's the same. Just like Indonesia has lots of different islands, each one being unique. And so it's not just one specific level, it's just a big multi-level system of Alzheimer's disease patients. So as Alzheimer's disease patients' as their disease advances, the patient might be competent to make smaller decisions, but not larger decisions. And I'll explore this a little bit more on the next slide. Also, just because someone has been diagnosed with Alzheimer's disease does not mean they are no longer competent to make decisions, medical decisions, or other decisions. It's a progressive disease, and the patient might be diagnosed with Alzheimer's disease when they're just having basic memory problems, and they still might be very competent to make decisions for themselves at this point. So in simple terms, Alzheimer's disease can be divided into 3 different stages: early, middle, and late. So in the early stages of the disease, the patient is mostly competent to make medical-related decisions. Occasionally, they will have some memory problems and forget things they have learned recently. But at this point in the disease, I think the family ought to play a supportive role for the patient. In the middle stages of the disease, competency begins to diminish, and patients might not be competent to make their own medical decisions as patients' mental abilities begin to decline and they experience changes in personality. The family ought to begin to take on a bigger role for the patient. In the late stages of Alzheimer's disease, patients are no longer competent to make decisions about many things. They experience extreme changes in behavior, and they lose the ability to communicate properly. They also begin to experience physical side effects like trouble walking, trouble eating, and trouble controlling their bladder. And at this stage in the disease, the family ought to become the decision maker because patients can no longer care for themselves. So the role of the family is very important in Alzheimer's disease patients. Oftentimes, it is the family that will recognize changes in the patient's daily life that indicate this lack of competence. The family will often be the ones to convince the patient to go to the doctor. They will be the ones to take away the patient's car keys and many other things because the family is often around the loved ones with Alzheimer's disease, and they will be able to tell when their loved one's decision-making begins to decline. I think it's important that the physician takes note of the family's thoughts because it can be hard to determine competency in the 15 to 20 minutes the doctor gets to see the patient, and symptoms are not very severe at the beginning of Alzheimer's disease, like forgetfulness and other symptoms might not be present in the 20 minutes patients are at the doctor's office. So it's important to listen to the family because with Alzheimer's disease, you don't always see the symptoms 24/7. You might see at the beginning of the disease evidence of it at certain points in the day, but that might not come across in the 15 to 20 minutes they're in the doctor's office. The family ought to get progressively more involved as the Alzheimer's disease patient as their case becomes more severe. So in Texas specifically, what role does the family have? So in an article from Cherry and Engelhardt in talking about the role of the family in Texas, they write, although at the surface there is an affirmation of the centrality of individuals, space is also made for families as the presumed locus for appropriate medical decision making. So Texas is independently recognizing the moral authority of the family to make decisions for or with that patient. Even if that patient, for example, is estranged, the hospital will search for family members, even if you haven't talked to, let's say, your brother in 10 years. They will listen to what your brother says because they will always turn to the family. Furthermore, Cherry and Engelhardt say that the medical decision-making process is a multi-ballot and multi-level process. So in this, they say like physicians, patients, and families all play an important role in this process. But then what happens, we're talking about this importance of the family, but what happens if the patient does not have a family or they have a bad family? So occasionally there is a bad situation, but we shouldn't make bad situations the standard. Like why would we treat a familyless person or a bad abusive family as the norm? So policy needs not to look at exceptions, but rather the general. That being said, some families are bad, and it is important for the doctor to look for signs of abuse, to ask for a follow-up appointment, and if they don't show up or don't schedule a follow-up, then that could be concerning. Also, bruises on arms and bad family interactions should make them note things that might indicate signs of abuse or neglect. So for people who don't have a family or have a bad family, it's important to put surrogates, whether that surrogate is a family member or someone else you trust, in place while still competent. Doctors early on should say, I understand that you don't want your family to help, but who do you trust? And who do you want your power of attorney to be, or what do you want your advance directive to say? And to let the patient know that they should get that stuff in order before their competency begins to diminish. So finally, kind of my conclusions from this. So Alzheimer's disease patients lose competency with time, and I believe that the family ought to take a role in helping to make medical decisions for their family member as this disease progresses. So even though we live in a very individualistic society, what happens if the individual is no longer a person in the philosophical sense anymore? So if they don't interact with the society, or the decisions they are making today are 180-degree different of what they would normally say or what they used to say, then they might not be competent to make those decisions anymore. And when this happens, the family needs to play a larger role in the decision-making process. If the individual has a bad family or no family, it's important that surrogates and advance directives are in place before an individual loses competency. So here are some of my key references, definitely not all of them, and that's my thesis presentation. I just want to say thank you so much to my advisor, Dr. Cherry, for all the support and guidance he has given me throughout this process, and for becoming my advisor kind of last minute. Also, thank you to Dr. Wolk for making this symposium happen in whatever way she could given this situation. And then lastly, thank you to my family and friends for always keeping me happy and confident, and for helping me make it through all 4 years at St. Ed's. Now, any questions?
Thank you, Megan, and thank you for putting up with us having to get through that. Dr. Cherry is Megan's mentor, and Dr. Cherry, if you'd like to say a few words, please feel free to do so. And if anybody has any questions, you can type them into the chat box and I will read them, or Megan can answer them directly from the chat box. Thanks.
So do I get to ask a question too?
Sure, I'm sure she'd be expecting that.
First, let me say one of the great joys of being a professor is to have wonderful students who challenge you and push you to think through things very carefully. I've learned a great deal in the last semester. It's been really a lot of fun for me because Megan's been a wonderful student. But my question for you really is for you to reflect on. What did you find to be the most interesting or maybe unexpected result of your research?
Yeah, so I think kind of the most interesting thing I've learned through this process was just connecting the science of Alzheimer's disease to then competency in the medical ethics side of things. Because through my research, I kind of saw that Alzheimer's disease is progressive and it spreads to different parts of the brain at different points in the disease. And so as it spreads, we see these different stages of Alzheimer's kind of progress, and they start to lose things like memory abilities, decision-making capacity. And so then that led me into my thesis and looking at the competency and all of that. So I think tying the science perspective and the competency and being able to see that through changes in the brain was really the most interesting part for me.
Okay, thank you, Megan. Thank you, Dr. Cherry. Are there other questions for Megan?
Looks like there's one in the chat.
There is. There's one in the chat. Okay, so from Angel, what made you choose Alzheimer's patients specifically?
Yeah, so when I was at Age of Central Texas, which is an organization in Austin that works with kind of all kinds of older people, I worked specifically with Alzheimer's patients. And so I think that's really what got me interested in the first place. And then I was also starting to do some lab research on campus that was really more focused on literature reviews and stuff like that. But I was dealing with Alzheimer's disease and more of the science side of things. So then combining those two experiences kind of really led me to choose Alzheimer's specifically.
Any other questions for Megan? Megan?
There's one by Dr. Paul in the Zoom group chat.
Where is it? Okay. Okay. So Dr. Prawl is saying to everyone, thanks for the good presentation. Do you see your investigation of the concept or definition of competency as being transferable or applicable to other situations and contexts? Thinking about legal issues, for example.
Yeah, I would say, well, thank you for watching. I would say yes, very much so. Just in some of the research I was doing, some of the research was focused on policy and law, and they used competency more and then competency to make decisions, whereas medical papers were talking about the capacity to make decisions as determined by different tests and stuff. I kind of use that term in a lot of different ways, and I think, yeah, definitely it could be used in other contexts like legal issues, for example.
Thank you.
Okay, any other questions? I think it's time for us to move on to Noah's presentation. So thanks again, Megan. Thank you, Dr. Cherry, and everybody who participated.
Thank you.
Okay, real quick.